there you go with our first slide. So these are some of the things that we're going to talk about today. What is triple negative breast cancer? How is it treated? Why is it so aggressive? Talk a little bit about survivorship as well, different treatment options. But first, MC is going to talk a little bit, just kind of give you sort of a background about cancer in general. We'll take it from there. And if you have any questions, just put them in the chat. Victoria will be just compiling those questions, and then we'll answer them for you at the end. So please know that neither one of us are doctors. We hope someday maybe to play doctors on TV, but neither one of us is a medical professional. We've been working in this field for a very long time, and have some knowledge, particularly about triple negative disease, that we wanted to share with you tonight. So I know that there are several people who have been diagnosed, so you could probably add your own experience and expertise to the conversation. And I also noticed there are a lot of Canadians in the house tonight, so welcome, Canadians. So we can go to the next slide. I'll turn it over to MC for a bit.
Hey, everybody. So what is cancer? The human of trillions of cells that normally grow and divide over the course of your lifetime. But when cells are abnormal or get old, they usually die. But cancer starts when something goes wrong with this process. Old cells don't die and instead grow out of control, forming new abnormal cells that eventually form a tumor. So breast cancer occurs when breast tissue cells grow out of control. Next slide. So we're going to go over a few types of breast cancer. So we have invasive breast cancer. I've heard we have a couple of invasive ductal carcinoma, invasive lobular, and then we have non-invasive breast cancer, DCIS, and then lobular carcinoma, LCIS. And I'm just going to go over some definitions and a little more background of those, okay? So invasive breast cancer is when it means that it's spread into the surrounding breast tissue or infiltrating the breast tissue. And the two most common types of invasive breast cancer are defined by where in the breast they begin to grow. So invasive ductal carcinoma, IDC, is invasive breast cancer that starts in the milk ducts, the tubes that carry the milk from the lobules to the nipple. And that is the most common type of breast cancer. About 80% of all breast cancers are invasive ductal carcinomas. Invasive lobular carcinoma, ILC, is invasive breast cancer that starts in the lobules, the glands that are in the breast that produce milk. It is the second most common type of breast cancer, but it only makes up about 10% of all invasive breast cancers. And some types of invasive breast cancers have features that affect how they develop and how they're treated. Now, triple negative breast cancer, it is an aggressive type of invasive breast cancer that tests negative for estrogen receptors, it tests negative for progesterone receptors, and it does not have any extra HER2 proteins. So about 12% of all invasive breast cancers are triple negative. And so I'm going to go over a little bit about metastatic breast cancer because I heard someone introducing themselves are metastatic. So metastatic breast cancer, also called stage 4 breast cancer, is invasive breast cancer that has spread, and you'll also hear the term metastasize, to parts of the body away from the breast, such as in the bones, liver, lungs, or brain. Breast cancer can also come back in another part of the body months or even years later after the original treatment, and that is called a metastatic recurrence. But some people are initially diagnosed with metastatic disease out the gate, and that is called de novo metastatic breast cancer. And recurrent breast cancer is invasive breast cancer that comes back months or years after treatment, but it occurs in the same breast. So that is called a local recurrence. And it's nearby the lymph nodes in the armpit or collarbone. That is called a regional recurrence. Or in another part of the body, it's metastatic or a distant recurrence. And then really quick overview of what non-invasive means. So that is when breast cancer is non-invasive or situ, has not spread beyond the breast tissue where it started. So non-invasive cancers are also called precancers. There are two main types of non-invasive breast cancer, and that is the ductal carcinoma in situ, and that is DCIS. And that is the non-invasive breast cancer that is not spread outside of the milk ducts where it started. I'm handing it back over to Christine.
Thank you. So next slide. So is everyone kind of familiar with these main subtypes of breast cancer? You can use your little reactions to maybe give me a thumbs up or a thumbs down, but I'll go through them a little bit. So, you know, way back when, like when I was diagnosed, maybe when Fran was diagnosed, thinking was that breast cancer is kind of very similar, right? It's all kind of one disease, but scientists have learned that breast cancer is not one disease. And it's really classified by the subtypes that provide information about receptors that fuel the cancer's growth. So when breast cancer is confirmed, pathologists look for biomarkers that exist within the tumor. And the biomarkers like estrogen and progesterone or HER2, they're either negative or positive. And that provides information about how to treat the cancer, provides information about what fuels the cancer to grow. And triple negative has no known receptors. So it's estrogen and progesterone negative and HER2 negative. But also some cancers are triple positive. So that means they're estrogen and progesterone positive and HER2 positive as well. So within these subtypes, there are other subtypes. So this is when you can get really sort of into the weeds. But some of these subtypes you might have heard about. They're called luminal A or B. And they tend to be like a lower grade and slower growing cancers. But treatment options really depend on what biomarkers are present in the tumor. But here are some interesting facts to remember. So most breast cancers are HR positive. So HR is estrogen and progesterone positive. That's 70 to 80% are HR positive. HER2 positive accounts for about 15 to 20% of breast cancers. And these cancers tend to grow and spread faster than HR breast cancers, but respond well to treatment. And there are very effective drugs that target the HER2 protein. Triple negative breast cancer is ER, estrogen, and progesterone negative and HER2 negative, and it makes up about 10% of breast cancers. And triple negative breast cancer is often categorized as high grade, more aggressive. So we'll talk about different treatments, and each treatment that we're going to talk about is considered to be the standard of care. And the standard of care in all cancers is the recommended treatment, and it's determined by academic research and experts in the field. And the drugs used for treatment are approved by the FDA. So next slide, please. So we talked a little bit already about what triple negative breast cancer is. And it is invasive breast cancer that is estrogen receptor negative, progesterone receptor negative, and HER2 negative. So it means that the cancer cells don't have receptors for the hormones, estrogen and progesterone, and don't make too much of the HER2 protein. So triple negative breast cancer doesn't respond to hormonal therapy and does not respond to the targeted medication that targets the HER2 protein. And I think I already said about 10 to 15 is the estimate of all breast cancers that are triple negative. And triple negative has been thought of and treated as one disease, but scientists have now found that there are several subtypes, and they categorize about 6 different subtypes of triple negative disease. We're not going to get too in the weeds about that, but I think the things to remember are kind of basal-like is something that you'll hear a lot to describe a triple negative breast cancer, basal-like 1 or basal-like 2. And that means that that it's sort of more aggressive, and it's defined by like a robust cluster of genes. So we can get like deep into the science of that, but it's sort of a lot. But just to know that triple negative is kind of aggressive, and basal-like 1 and 2 are sort of the most common terms that you'll hear about the subtypes of triple negative. So next slide. So who gets triple negative disease? So it's more common in women that are younger than 40, so usually premenopausal women, Black women, and those who have a BRCA1 mutation. So we all have the BRCA gene, right? Some people have a mutation in that gene. So triple negative breast cancer is usually more aggressive. It's a little harder to treat because there are less options, and it's a little more likely to come back or recur than cancers that are hormone receptor positive or HER2 positive. And the symptoms, staging, diagnosis, and survivorship care for triple negative cancers are the same as other invasive ductal carcinomas. And I think I said, yeah, most triple negative occurs in premenopausal women and accounts for about younger women who account for about 15 to 20% of all breast cancer patients. So next slide. So why is triple negative aggressive? So it's considered to be aggressive because it grows quickly. It's more likely to have a spread at the time that it's found. It's more likely than the other cancers to come back after treatment. And in general, the outlook is not quite as good as other types of breast cancer. So compared with the other subtypes of breast cancer, the survival time of TNBC patients can be shorter. The mortality rate tends to be higher after 5 years. So I know that there's a newly diagnosed patient here, and I know that there are several of us who have been diagnosed with triple negative. The good news is that when the treatment works, it really works. Right? It's very sensitive to chemotherapy, and there's a good chance that it could, I'm going to use the word cure, that it could be cured. So the thing about triple negative being aggressive is that in some cancers, I think MC may have said this earlier, like in HR positive cancers, there could be a recurrence 5, 10, 15, sometimes 20 years down the line after the first diagnosis. But in triple negative, if it comes back, it tends to come back sooner, maybe within the first 2 years or so. And if triple negative is going to metastasize, it usually happens maybe within 3 years or so after diagnosis. So of course, you know, that doesn't mean that it's going to happen. Doesn't mean that it happens that way for everyone. Everyone's an individual, and everyone's cancer is a little bit different. Next slide. So how is TNBC treated? So there are a lot more options now. I was diagnosed in 2000, right? So over 20 years ago, when triple negative was not called triple negative, and there was one treatment, and that was it. And lately, there's been several drugs approved for the treatment of triple negative breast cancer. And this is the most activity we've seen in some time. But sometimes people have surgery first, right? So if the early stage triple negative breast cancer tumor is small enough to be removed by surgery, then people will either have a lumpectomy or a mastectomy. And the lymph nodes will be checked to see if there's any cancer cells in the lymph nodes. In certain cases, where maybe like a large tumor or there are lymph nodes involved, then radiation may follow surgery. And then people, particularly if there are lymph nodes involved, right, lymph nodes that have been found to have cancer, then most likely people will be given chemotherapy. And chemotherapy, as you probably know, is provided to reduce the chances of the cancer coming back. And then women who have a mutation in the BRCA gene, the BRCA gene, 1 or 2, and who have surgery, and it's found that the tumor is larger than 2 centimeters, but no bigger than 5 centimeters, or there are lymph nodes involved, then a new targeted drug for that population called PARP inhibitors may be given for a year after the chemotherapy. And this could help some women live longer with the disease. So is everyone familiar with PARP inhibitors? It's kind of a new drug. They're used widely in other cancers like ovarian cancer and some other GYN cancers. But what it does, it works by blocking the PARP proteins. So because tumor cells with the mutated BRCA gene already have trouble repairing damaged DNA, blocking the PARP protein often leads to the death of these cells. And these drugs, PARP inhibitors, are pills, they're oral medication, and they're taken once or twice a day. And doctors can use them in different ways to treat triple negative breast cancer. But it is specifically for those who have a mutation in the BRCA1 gene. Next slide, please. So lately there's been, sort of a change in the standard of care where surgery comes second. So chemotherapy is often now given before surgery by itself or with an immunotherapy treatment called Keytruda. And the reason that's done is that we shrink the large tumor and it helps to treat any lymph nodes that may be involved as well. And then if the cancer is still found, then surgery occurs after that. So this kind of treatment is called neoadjuvant, neo meaning before, new chemotherapy. And so this is sort of the new standard of care. And then if there's maybe some residual disease left over, an oral chemo drug, and I think someone said that they were on it, Xeloda, might be given then for a period of time. Sometimes more Keytruda, or the immunotherapy, might be given after surgery, and that would be given to help reduce the chances of the cancer coming back. And then sometimes a PARP inhibitor will be given as well. Next slide. So stage 4 triple negative breast cancer or metastatic triple negative disease. Chemotherapy is often used when the cancer has spread to other parts of the body. Some of the chemo drugs are the anthracyclines, the taxanes, and eribulin, some other chemotherapy drugs, and they may be used alone or in combination with one another. And again, if there's a mutation in the BRCA gene, then a PARP inhibitor might be utilized as well. And then recently there's been this discovery about PDL1, which is a protein. And there's a PDL1 protein is found in maybe 1 out of every 5 or so triple negative breast cancers. And if that is found, then there's some targeted therapies that could target that PDL1 protein. And then most recently, for metastatic triple negative disease is a new drug called Trodelvy. And this is a drug that is given to people who have had at least 2 other treatments for metastatic triple negative disease. And this is it's kind of a new class of drug called an antibody drug conjugate. And is anyone familiar with what that is? It's kind of like, I think they call it like the Trojan horse kind of medication. So it doesn't kill all the cells, it just kills the tumor cells and it spares the healthy cells. So it gets into the cell, kind of like disguised, like in the Trojan horse. And once it's there, it releases its payload and then kills the tumor cells. So it's sort of a smart drug, and side effects are supposed to be, not as harsh as chemotherapy can sometimes be. Next slide, please. So, we know that triple negative breast cancer is associated with an early recurrence, maybe within first couple of years, lower survival rates than other subtypes. And the median time to detection of recurrence is 1.6 years. So if there is a recurrence, some will have the recurrence sooner, some later. The average is 1.6 years. And 25% of patients, the recurrence was already detected within the first year after breast cancer diagnosis. And scientists know this, and that's why all these new drugs have come out, and a lot of talk about residual disease after treatment. So a lot of research is being done. More research than we've ever seen before in triple negative is being done. MC shaking her head. She reviews research for the Department of Defense, where a ton of breast cancer research is funded. And we're seeing much more research for triple negative disease. And, as I stated before, that triple negative disease is very, very sensitive to chemotherapy. And there's a very high rate of pathological complete response or remission. So if it works well. And, scientists and clinicians are very hesitant to call it a cure, right? But I would say 22 years out from diagnosis, I've never taken anything after chemotherapy. I would say I'm cured. They call it pathological complete remission, so it's total remission, and that's higher than any other breast cancer subtype. And because of the fact that there are very few molecular targets, right? So there's the PDL1 now, and there's a mutation in the BRCA gene that has some targeted therapy now for TNBC, but these treatments are not as widely utilized because it's a small percentage of patients who have a PDL1 protein or a mutation in the BRCA gene. So triple negative does not have as many drugs in its arsenal to treat as the other subtypes. But the drugs that are there could be very, very effective, and you can have a pathological complete remission. So let me turn it over to my colleague, MC, and she'll talk about survivorship.
All right. My goodness. Isn't Christine so brilliant? Goodness. So let's talk about survivorship, okay? That can encompass all the different types of cancers, right? So I wanted to know how many of you have ever felt a fear of recurrence? Show of hands. Yep. I'm with you. So have I. How many of you have ever felt some anxiety or stress? Show of hands. Anybody? Yep. All right. Because I'm like, I know, can't be alone. Okay. And then curious, how many of you have felt the fatigue or had some cognitive issues? Anyone? Yep. I hear ya. So I'm gonna get into some facts here. So typically after 5 years, your risk of recurrence goes down. In fact, as time goes on, your risk for recurrence may be lower than that of someone treated for estrogen receptor positive breast cancer. Most women with triple negative breast cancer never have a metastatic recurrence or a new cancer. But of course, as I always like to say, every body is different. So that's why you're going to have monitoring. There's going to be ongoing monitoring, and that can differ from, provider to provider, wherever you're treated. And so for some, after treatment ends, you'll see your oncologist every 3 to 6 months. And then for like that first 1 or 2 years, and then it goes from every 6 months to every 12 months, possibly for the next 3 to 4 years, and then once a year. So that is something that will be talked about with your oncologist of how, frequently they want to see you in the beginning and then kind of space it out. But when it starts to get spaced out, you start to get a little nervous, because you're used to that routine of when you were in treatment. You got a lot, you were going almost every day or at least every week. And then once you enter that survivorship stage, it can feel scary because I often use the visualization of sometimes we're just thrown out into the sea with a life jacket, trying to stay afloat, because all of a sudden, we're not seeing our medical team all the time. And so that can just be, it can be kind of scary sometimes, and that's okay. And that is, quote unquote, normal. Some oncologists, they might provide scans every few months to look for any type of cancer that may have spread. So again, you're always going to be monitored. There's always going to be imaging, and that imaging is getting better and better. Survivorship, as you can see on this slide, it can be marked with some physical changes, right? I know I can even say for myself, lost my fertility. So there's been, you can have changes in your reproductive functioning, your sexual desire. There can be nerve damage, chemo-induced peripheral neuropathy. There can be the cognitive difficulties, or as you might have heard, chemo brain, right? Fatigue, there can be hearing loss, some heart issues, because sometimes, depending on what type of chemo you have to be on, they have to check your heart to make sure it can handle the chemo. And then, of course, the emotional changes, right? The stress, the anxiety, depression, the fear. And that could be tough to deal with. And that is why we're here, right? That's why you're here at Share. That's why you're here tonight, is to know that you can't go through this alone. You need that support. You need to talk with others. It's too big to handle alone. And sometimes it can feel difficult too, to talk, to your family members, because they may not get it. They may think, oh, well, you're in the survivorship stage, you should be fine now. So that's why it's really important to reach out and find your support and find your community, which you have within Share. Next slide. So listed a few additional resources and information for you. But also, of course, check our Share website where we also have information as well. And that concludes our talk. Now we're ready for some Q&A.
And I see that we didn't put our own, and I created the slide, so it's my bad for sure. But for those of you that are triple negative, we